So let's get into it. Let's start with language. So you have this line here in the book, language is the architecture of thought. And I do have the book in front of me. So when you see me looking down, I'm looking at the book. Language is the architecture of thought. And you ground the audience in terms, kind of trying to create a space where everyone can get on the same page about terminology, things like sex versus gender, uterus, ovaries, and all of this. But I'm curious for you to speak to a little bit of the tension that can occur for individuals and also for doctors, for practitioners around finding language that is precise, sort of medically,
Mhm.
but also inclusive to the experience. And I'm going to interject sort of my perspective for a second, and hopefully you can sort of speak to it and maybe
Yeah.
teach me something, right? I have always felt that sort of precise anatomical language is the most inclusive because I'm not using pet names for anything and it's sort of more objective. But in the book, you point out lots of examples where that is not the experience for the patient. And so how do we do that all together? Like speak to this and
Yeah.
speak to all of us, both the practitioners and the patients and everybody.
That's a great question. And it's one that I spend a whole week on in my training for providers, which is the Gender-Affirming Menopause Care Certification course. The perspective that I come from is that trauma-informed languaging is a clinical modality. And if we cannot meet the clients where or patients or because I work with all kinds of people, so clients, patients, et cetera, if we can't meet them where they are, we aren't going to meet them at all. And so we're precluding them from accessing reliable or affirming care by sticking to a language that might be technically accurate, but induces dysphoria, or might be technically accurate, but alienates. And so in the case that in how I teach it, I really do teach that honoring a person's linguistic requests is a form of care, and that we really can't actually produce the desired provider patient relationship without accommodating. And so and I also like to point out that things like not to trigger anyone, but the word vagina, it means sheath for a sword. It's like the heterosexist sort of anti-woman even languaging that is built into the medical model is also something to be aware of, and something that we can, like, as we look at it on the whole, we can start sort of teasing that stuff out and being like, somebody made up this word at some point. Why is it more valid than front hole? Why is it more valid than whatever term that someone might use? And I do want to say, like, there's more work needed when you are working to accommodate people's linguistic requests, right? You need to do a whole intake appointment where you're like, what are the terms that you prefer? What are the terms that make you comfortable? What are the terms that you use for your body? And being able to arrive at that conversation, though, that's part of creating rapport in the relationship, as far as I'm concerned.
How much of that intake process do you think could be part of sort of structural intake forms versus must be contained within a conversation?
Definitely a lot of it can be done through paper forms or, digital engagement. I definitely teach also, like, audits. I have an audit tool for my providers where I have them audit, like, all of their forms. I have them audit their websites. I have them audit, whatever a client might be coming into contact with. I have them also work on training their staff appropriately, right? Because the doctor or provider is not the only person that the patient is going to be engaging with. So,
Absolutely.
like, all of those opportunities are opportunities for trauma informed care.